Thank you. So when I was given this talk with 8 minutes on latest in Cornea 2025, my dilemma was how latest is latest? Latest in India or latest in the world? Uh, should I do cornea and ocular surface or only cornea? Should I do medical advances, surgical advances, talk about stuff still in research stage or already in use? So this was just to explain to you my dilemma. Then I finally chose 7 items for the balance 7 minutes because I'd wasted 1 minute in this dilemma. So let's go with 7 items which I've selected. Item number 1, allergic conjunctivitis. So many new drugs have come out besides patenolol. There are still people using disodium chromoglycate for some strange reason. Just like there are some people using IDU for viral keratitis. But we have now bepotestin, we have L-caftidine, we have new data on frequent eye rubbing causing keratoconus. So if one thing, if you can stop eye rubbers, allergic conjunctivitis, you'll have done a service to them for future. They might not become future K-conus candidates. So get them to wear glasses. Get all your allergic conjunctivitis patients to wear glasses because the finger doesn't go in so easily. Even if it's 0.25 plus minus doesn't matter, but give them. I am a very big fan of tacrolimus. My favorite is Tacliment. No commercial interest with Orolab. They are lousy marketeers and lousy distributors, but it's well tolerated. So Tacliment is what I use. I often dilute 2% orosporin to make it 1% orosporin. Again, no financial interest in this. Let's go moving to dry eye. So 2017, Dews with Virendra Sangwan there came out with a new definition. And in that, one of the things that they talked about is its multifactorial, hyperosmolarity, and neurosensory abnormalities. So much so that in America now there is a drug for dry eye which is to be used as nasal drops. So you irritate the nose and get not reflex but basal secretion going. So Dews recommended a staged approach, first line, second line, third line treatment, which is not different from the earlier Dews as well. But basically environment modification, looking at blepharitis, we are taught to continuously, every time patient comes, look at MGD and oral secretagogues, autologous serum drops, and very advanced cases, steroids and surgery. Third item, new hair splitting on cornea splitting. So we have PDEC invented by Amar Agarwal, Susan Jacob and group, where Dr. Dua first made it easy by telling us that there is a pre-decimase layer called a thicker layer, the stronger layer of stroma, which is now the Dua's layer. So Amar goes from the front, puts a big bubble, removes the thing as if you're doing a DALC, throws that away, and then the remaining is the Dua's layer, the decimase and the endothelium, which is much easier to do than DSEC and DMEC, and he gets better results than DSEC and DMEC in his hands. DMEC is, of course, been around after DSEC. And then as a comparison, you have something called ultra-thin DSEC, which is around 100 microns. You use the microkeratome twice. Item 4 is vision graft to be made in India very soon. I talk about it because our eye bank in Mumbai is involved in this thing. It's a cornea which is irradiated. So all cells have been destroyed, all keratocytes, epithelial cells, the endothelium, all has been destroyed. You have nice thick stroma there. You can store it at room temperature for 3 years, something which you could do only in glycerol preserved corneas in the past. But now you can get these irradiated corneas. So we're working with the Baba Atomic to try and develop this so that we'll be able to give it for therapeutic keratoplasty all across the country. Every medical college will supply. Hopefully, it's been around since 10 years in the US. They're using it more for glaucoma valve patch grafts instead of sclera. But we will be able to use it shortly for keratoplasty. Item 5 is SLET. I wanted to highlight it because it's an Indian invention, Virendra Sangwan et al. It took the world by storm. It's just over about 2011, I think, when he came out with this. And it's revolutionized single eye chemical burn treatment to get you to near normal, most times not needing a keratoplasty. It's the SLET stands for simple limbal epithelial transplants. Item 6, new research in keratoectasia, so the ballooning of the cornea. We know that epithelium now plays a pivotal role in keratoconus progression. Eye rubbers, as I told you. Rohit Shetty and group are doing a tier analysis by which they'll be able to give you, you just dip your Sharmas there and put it in that, and it'll give you all sorts of information. And in the treatment, Susan Jacob again from Amar Agarwal's group has come out with CARES, which has taken the world by storm, right from South America, North America, Europe, everywhere, where you use the patient's eye-bank corneal ring segments to replace the intakes, which is costly and which is prone to complications. This CARES over the course of time integrates very well in the cornea. It's easy to put in, easy to remove, easier if you have a femtosecond with you, of course. Item 7, keratoprosthesis is becoming mainstream, and I have a vested interest, not a commercial interest. Oralab was given the license to make the Boston K-Pro, the only company outside of the US which is licensed. And then Sayan Basu and others from LVPI designed a special K-Pro through the lid, which is a modification of the Boston Type 2, which is called the Oro K-Pro. Thank you. The Pintucci is something which I have been doing since 1997. Stopped now because the supply has dried up with the premature death of Pintucci. And but the MOKP, which is similar except that it uses the tooth, over 100 cases done last 10 years at SN, that has come of age. So K prosthesis is becoming mainstream. I thank you so much for